Hello viewers, you're welcome once again to Africa Live. Yes, Africa Live is a platform where we look at issues, contemporary issues, salient issues about the happenings in Africa, not just as they happen to Africans in Africa, but also as they happen to Africans in diaspora, because they're all from the same stream. And home, they say, is where you ought to go to sooner or later. Ladies and gentlemen, a very special person here that's coming to our studios to look at the issue of the effectiveness of the primary, secondary, and tertiary healthcare system in Nigeria. And this is a very core issue. You want to look at all the several decades of Nigeria's existence. You want to look at the amount of money over those decades that's been sunk into healthcare services. And then we want to say why, or why not, that the public service has failed or succeeded. And that we need to look at today. And with me in the studio to do justice to that is Professor Rotimi Jaiyesimi. Professor Rotimi Jaiyesimi is a fellowship of 5 main medical organizations, of gynaecologists, of the Western College of Surgeons, and so on and so forth. Professor Jaiyesimi is here in London, and he is an Associate Medical Director for Patient Safety at the Basildon and Thurrock University Hospital Trust in Essex. He's a visiting professor of the Faculty of Health Sciences at the University of Sunderland, and he's also a visiting professor of law. Yes, law, you heard me, at the University of Ibadan, Nigeria's primary tertiary institution. Thank you very much. You're welcome to the program today.
Lovely. Thank you for having me. Thanks.
Thank you very much. Yes, we want to look at Nigeria today.
Yes.
And Nigeria has been in existence for over 53, 54 years as well.
That's correct.
And we want to look at what has been the trend. We grew from those who seem to know, who were supposed to be the best, the British people. And we have grown, to look at that, we've copied all sorts of policies to ensure that, yes, indeed, we can service health care. For the sake of our viewers, can you just explain what the primary, secondary, and tertiary healthcare policies would imply to any nation state?
There are 3 tiers of health services in Nigeria. Primary care, which is under the local government authority. We have 774 local government authorities in Nigeria. Then you have the secondary care, which is run by state governments. We have 36 states. And tertiary centers, the likes of UCH in Ibadan, Lagos University Hospital in Lagos, Abu in Zaria. These are under the federal government. So those are tertiary specialist centers. General hospitals, yeah, you do have some specialization, but when you need to refer for further care, then you send them to the tertiary ones, and that's run by the federal government.
Okay, thank you very much. Now, let's start with how effective these policies have been. Let's take a blanket approach. Would you say that all these healthcare services are effective to Nigeria and to Nigerians as a whole today?
They're not effective to some extent. And the reason they're not effective is because there's no joint up working. Now, if you're in primary care and it's not well funded and you're a patient, you'd rather go to where there are doctors, where you'll receive treatment. So you find people going to UCH for malaria or for diarrhea. Such illnesses should be treated at the primary care level. Okay. But there's no referral system that sends you from primary care to secondary care to tertiary care. And that's why the system hasn't been very, very effective. Again, it's multifactorial. Nobody wants, the doctors, the nurses don't want to go to the rural areas, so nobody wants to work in primary health care centers. Do we have enough practitioners who can work in primary health care? Perhaps not. People want to live in the urban centers. Nobody wants to go to rural centers where you will get primary health centers. But if incentives are given or a form of structures put in place where you have rotation of doctors and nurses, maybe for a short time, 3 months, to go to primary health care centers, then that's possible. So what I'm trying to say is the three arms of government really have to sit down and look at how to staff the three tiers and a referral pathway. Most of the disease burden in Nigeria can be treated at primary care health level. But what you find at the moment, like I said, is people go to the tertiary centers for really what can be handled in primary care. And in doing so, you overwhelm the teaching hospitals. So they should focus on specialist care. But when you have lots of patients coming to you, then it affects the quality of service you can give.
Okay. But you struck a chord there. People are meant to go to the primary health care venues, the local hospitals, the clinics.
That's correct.
That are very close to them in the rural areas.
Yes.
But why should they choose to leave the clinics and go to general hospitals, which are secondary areas primarily? I mean, why should they abandon a clinic and think that for malaria you must go to there? I think that may impel upon the situation that the people may distrust or find distrust in the quality of services, even at the primary health care level.
I am happy that when you were asking or introducing, you spoke about decades of investment in healthcare. So what we have at the moment is not the doing or making of the current government, it's historical. Funding to the primary healthcare centers hasn't really been good enough. Most primary healthcare centers are run down, overgrown by grass, and understaffed, no nurses. You don't really need a doctor in a primary healthcare center. You could have nurses running it. But like I said, if there's no nurse, no drugs, then patients will vote with their feet. And that's what's happening. Investment in primary healthcare level has been very, very poor. And that's why the primary healthcare centers are what they are. And you will, or you may remember that when this new government came into power, one of the things they promised was to revamp the primary healthcare centers by promising to refurbish or re-equip about 10,000 primary healthcare centers. And they have started to do that.
If Lagos State, for example, is still saying that a fresh doctor under his service earns to about 207,000 naira per month, and a consultant earns about 70,000 per month, how green will the doctors expect the pasture to be?
Well, again, it's a complex situation. The grass is always green on the other side. My father's side is always bigger than yours. The pay, relatively, is good. But you've also got to be mindful of the fact that if I were going to send my son, if I were living in Nigeria, and I was going to send my son to one of the best universities, it probably would be one of the private universities where the fees are high. Again, can you manage that? And again, people at home would rather send their children abroad where they pay enormous fees. If you convert that into Naira, is it adequate? But if you look at the Nigerian context in terms of salary scales in academics, it's fairly, when I talk to my colleagues, it's fairly reasonable, they're comfortable, but when they look out and see what people earn abroad, they think, wow, that's big money. But they forget that you pay 40-50% tax They forget that there's a lot of accountability. Americans start work rounds at 6:30 in the morning, or 7:30. So it's not as
as smooth as
if you're paying 50% tax, and you pay all sorts of outgoings, then it's when they get here, then they know it's not as rosy as they think it is. So the pay in Nigeria is good, that's what I say. It can be better, everybody wants more money, but in relative terms, like you said, minimum wage, 20,000. A driver in Nigeria earns about 30,000 per month. And if you say, some people earn up to $1 million per month in Nigeria, so that's good money.
Now that implies quite a bit and quite a lot. If so much is given to the medical personnel, not just doctors alone, it's given to the medical personnel, pharmacists, cardiologists, nurses, midwives, the X-ray technicians, the radiographers, and stuff, and all of them like that. If so much is given to them, the infrastructure, the physical infrastructure that should enable them to work, are they adequate? Are they adequately staffed? Adequately and technically equipped?
I was going to mention that. If you look at 2015, 2014, there were so many strikes. If it wasn't the doctors on strike, it was the nurses on strike or the technicians on strike. When you have hospitals being closed or clinics being closed, you as a professional, you don't get that satisfaction in what you do. And perhaps that's one of the other reasons why people would rather go to South Africa, Rwanda to practice. Because, for 3 months you may be sitting down at home doing nothing because the hospitals are on strike. There's disharmony between the different professions in the health sector. Again, that doesn't bode well for quality healthcare services. Funding equipment, big problem. Basic things such as water, not all hospitals have water running from the tap. Drugs, equipment, maintenance of equipment. Again, not many hospitals have it. Cancer centers, there are very few cancer centers in Nigeria. So these are the issues, the problems the current government is having to grapple with.
Interesting. As we go on, it does create an impression that it's more like we are just there to say there's an irresponsibility factor that is rather doing the people in than actually helping them. And government has a responsibility of delivering a very effective health service to the people. Let us start with the infant mortality rate, then the maternal bit of it. And when you look at this, all these are all imbued in part of the MDGs for 2015, which are targets for us to realize. Do you think we have done anything close to that?
As a nation, no. We did not hit the target, the Millennium Development Goal 15. Nigeria still has the second highest maternal mortality rate in the world. It varies from state to state, 500 to almost 1,000 per 100,000 live births. And that's about 400, 500 people dying every day in Nigeria from pregnancy-related issues. Ondo State did set up a program, and they were able to achieve the target. If you ask me how they did it, I might.
You should give us what
you have. We were talking about primary healthcare centers, secondly not being well equipped. Now, when they're not well equipped, and again funding, people in the rural areas, even in some urban areas, don't have enough money. to go to receive healthcare. So they'd rather go to where they can afford it, traditional birth attendants, or even faith-based missions. And these have contributed to the high maternal mortality, the absence of health services. Now, what Ondo State did was to ask the traditional birth attendants, who probably will charge 400 maybe naira for each delivery, to say, look, okay, we'll give you 500 naira. Send your patients to the general hospital and we'll look after them. And each visit to the general hospital will give you an additional 100 naira. So that's more than what they would normally earn. And what the government also did was to say, yes, we'll give you money, but we're also going to equip you so that you learn some kind of trade, so that you are self-sufficient. And that's what the last administration, Governor Mimiko's government did. Oyeneye was also involved, Dr. Oyeneye. And they were able to bring down maternal mortality. Again, if you don't know statistics, you use data to drive improvement. Ondo State government now collects data on their maternal mortality. They produce a third report. And so you know how well you're doing. You have a benchmark, you know where you want to get, and you invest in it. So they've done that, and I hope they do continue it. And other states are trying to learn from what the government did. Ogun State had the ABA program, and other states are taking that on board as well.
Very interesting. The Ondo State example you gave is showing a very unorthodox solution to a problem. Can that be incorporated, for example, into the national planning for health as a way of solving the problem? Because government has done that before in Nigeria when they took education and they had the nomadic education, which took education to the nomads who are looking after their cattle. And now there's a unique one here. Would you support the re-examination of what's supposed to be the solution to all these issues? Because we have issues, fundamental issues of staffing, fundamental issues of infrastructure, physical and technical infrastructure, for primary health care. And then the secondary one, we've not even come to that yet, because that itself, I'm sure, will have its own very key issues. If the doctors and the nurses are going out, then the issue is, who is taking care of this?
Two things. If you look at the Chinese, they had the foot soldiers. They were not doctors, they were not nurses. They had the basic knowledge, and they were trained, and they went out to deliver healthcare at primary level. Now Nigeria has something similar. The community health extension workers. They are trained to do what they can do at primary healthcare level, treating malaria, treating diarrhea, the simple conditions. Traditional birth attendants are maybe slightly different breed of people. Labor is unpredictable. So if you're attending a birth as a traditional birth attendant and the woman starts bleeding and you're in a rural area and there's no referral pattern, there's no ambulance, how do you get that woman to the general hospital? And that's why women die from hemorrhage, then sepsis, infection, because they haven't been taught the art of hygiene, infection control, and that's why. So again, anybody can be taught if you invest in it. In Nigeria, yes, there are data, statistics are approximated. We don't have real quality data. And like I said, you need data to improve your services. So I will not say there's no role for traditional birth attendants. If they are well trained, well tutored, knowing when to refer, we talk of access, okay, yeah? What about referring to the next level? If there's no pattern or way for that patient to get there, then it's not going to happen. So it's that's why there has to be a joint of working, a referral pattern. There has to be investment in primary healthcare centres. Again, you can make it, what was the word? Where people want to go. You may not stay there for 12 years. What some hospitals are doing is they send doctors there. For example, the Society of Obstetrician and Gynaecology of Nigeria, what they're trying to do now is send a few consultants to go to primary healthcare level, secondary healthcare level, for a short while, could be a month, and do a rotation like that. So people are looking at different models of care, but the problem is you cannot tie people down to a particular job unless they are under some financial bond.
To do that. You brought me to an issue, and I think we should get back to that again, the issue of referral.
Yes.
Is that a case of a problem in the healthcare delivery policy? Because if there's a bridge between the primary healthcare system in terms of referral to the secondary, then there's a major problem.
Yeah.
And then we need to tie it down to saying whether, if there's a problem there, really, is it something that has to be strictly a referral, as in you have to write a letter and push the person, because most primary health care patients are outpatients. You know, is it that you have to write a note and push them off there? Or, like you mentioned, is it a case where the ambulances are simply restricted to the cities and simply tied down to the general hospitals and the tertiary healthcare delivery systems, and there is none around? Because if it comes to that, if something does go wrong at the primary health care, you are leaving a lot too much to the patient. And these are places where the income per capita per head is low, occupational distribution is quite restricted, and very, very modified, so that it is not able to escalate as it when due to allow this to happen.
If you look at the budget allocation, the primary healthcare centres are run by local government authorities. The funding for primary healthcare services is inadequate, just like the other tiers of healthcare delivery. And if there's no funding, there'll be no service. But even let's assume you have nurses or some practitioners there. If there's a problem in, let's for example say, Erua, how do you get that person to the general hospital? Yes, it can be tricky. What some people have done in the past is get their own mode of transport, bicycles turned into ambulances. But what we really need is a link-up. Ambulance service, whether it's going to be based in the general hospital and they go and pick up the patient, or you have one in a primary healthcare centre that can take patients out when needed. Telemedicine, again, might be helpful here, where you're able to telephone, say, the secondary care or tertiary care, and say, this is what is happening to my patient in this primary healthcare centre. What should we do? Don't leave it till too late. There has to be, this is where guidelines, knowing when to refer the patient. But I think we have a long way to go. Government is tackling it various ways. There's a program called Saving 1 Million Lives, where the World Bank has given Nigeria about $500 million to invest in health. And what the current government has done is to say it's going to be, we'll give you money, but further disbursements will depend on your output. So we're now beginning to hold people accountable for money allocated for projects. That didn't happen in the past. We all know the situation where money is allocated for something, but it goes into other projects or into other areas. But people are now talking about accountability. Foreign donors want to know how the money is spent, and there's some progress. I think people are beginning to ask questions. Where is the money? How did you spend the money? Show us how you spend the money.